I am Sang-Min Park from Seoul National University Bundang Hospital. It is my pleasure to share with you the efficacy and safety data from two multi-center randomized trials comparing biportal endoscopic and microscopic surgery, one for lumbar disc herniation, the other for lumbar spinal stenosis. I have no conflicts of interest to declare. My message today fits on 3 lines: 2 pathologies, 2 RCTs, 1 question. And the question is simple. Does biportal endoscopy truly match the microscope across both major lumbar diseases? Today, I'll give you the answer. There are 2 clinical questions at the heart of this debate. The first is about efficacy. We test this with ODI, VAS, HIVD, and patient satisfaction. The second is about safety. We test this with wound dehiscence, CPK, and complication rates. The biportal technique was adopted widely and quickly. But the answers to these 2 questions until recently were missing. First, most published studies were retrospective. Second, no high-quality multi-center RCT existed. And third, lumbar disc herniation and stenosis differ in anatomy and surgical technique. Results from one pathology cannot be extrapolated to the other. Each disease required its own dedicated evidence. Our group has worked to fill that gap over the past 6 years. In 2020, we published a single-center LDH RCT in the Spine Journal. In 2023, we followed with a single-center LSS RCT, also in TSJ. In 2024, we pulled safety data from both trials in neurospine. Then, in 2025, we published the 6-center multi-center LDH RCT in the Bone and Joint Journal. And in 2026, the 6-center multi-center LSS RCT in Core. From single-center pilots to multi-center level won evidence over 6 years. Today, I will focus on those 2 multi-center RCTs, Indo EJD 2025 and Indops in Core 2026, along with 3 derivative post-hoc analyses on wound healing, spondylolisthesis, and cost-effectiveness. The 2 trials were designed as twin studies. Both were multi-center, 6-center, assessor-blind equivalence RCTs. The primary outcome in both was ODI score at 12 months. The equivalence margin was set at ±12.8. Because the same investigators used the same methodology, we can place the 2 results side by side, a rare and powerful comparison. A quick look at the consort flow. Endo, DOT-BA randomized 100 and analyzed 87 at 1 year. Endobs randomized 120 and analyzed 106 at 1 year. Both trials achieved over 80% 1-year follow-up retention. Here is the primary result. Equivalence was achieved in both diseases. For LDH, the mean ODI difference was 0.6 points. For LSS, the mean difference was -5 points. Both confidence intervals lie entirely within the equivalence margin. So, functional outcomes are equivalent for both pathologies. This is the first pillar of today's message, the efficacy confirmed. The clinical recovery curve ODI score overlap at every time point. Biportal and microscopic groups follow the same recovery pattern from 2 weeks through 12 months. VAS leg pain, EQ5D, patient satisfaction, return to work, and daily life. No significant difference in either trial. In LSS, back pain VAS was slightly lower with the biportal arm, 1.2 versus 2.1. But this difference is below the MCID of 1.8, meaning it is not clinically perceptible. So every patient perceived outcome, equivalent. All functional outcomes showed similar outcomes. So, patients do equally well. Now to safety, and I believe this is the strongest slide of today's talk. Wound dehiscence. In the LDH trial, BES was 0%, microscope was 10.6%. In the LSS trial, BES was 0%, microscope was 7%. 0 wound dehiscence with biportal in both trials. The same pattern twice, and that is strong evidence this is not chance. Serum CPK, our marker of muscle injury. In LDH, CPK was significantly lower in the bed group. Surgical site pain at 24 and 48 hours was also lower with bed. In LSS, the groups were comparable. The signal of reduced muscle trauma is most evident in the discectomy trial, where the relative difference in incision size is greatest. Other adverse events: durotomy, surgical site infection, neurologic complications, hematoma, and reoperation at 1 year, all comparable between groups in both trials. No safety signal against biportal in either pathology. Operative variables. In LSS, the operative time was 15 minutes shorter with Bell, and the canal decompression area was larger. In LDH, scar quality at 3 and 6 months was better with bed. Biportal is at least as efficient and often more so. Now to 3 post-hoc analyses. The first is a pooled wound dehiscence analysis combining both trials, 211 patients in total. In Biportal, 0%. In Microscope, 8.7%. Odds ratio is 0.046. We also identified risk factors. Incision length of 35 millimeters or more, with a relative risk of 15.4, the dominant predictor. Drainage above 100 milliliters, with a relative risk of 8.55, and WBC change, with a relative risk of 7.78. The incision itself is the dominant risk, and Biportal removes it. The second post-hoc asks, does concurrent grade I degenerative spondylolisthesis change the answer? In a subset of spinal stenosis patients with spondylolisthesis, the spondylolisthesis status did not significantly modify any clinical outcome. ODI, VAS, EQ5D, and complications were all comparable between biportal and microscopic groups. We did observe a more consistent early rise in dynamic translation after microscopic laminectomy, which warrants longer follow-up. Biportal remains safe even with a concurrent grade I slip. The third is a pooled cost-utility analysis, 187 patients. The key message is economic equivalence. The incremental cost was just minus $52, and the incremental collé just plus 0.022. And both confidence intervals cross 0, neither significant. At the Korean willingness to pay threshold, the probability favoring biportal was 94.9%. But the robust take-home is simpler. Biportal adds no economic burden. Cost is not a barrier. The choice should be driven by clinical factors, not cost. Putting it all together. 2 RCT showed different pathologies, different procedures, same conclusion. Primary ODI showed equivalent. No wound dehiscence in biportal group. Lower muscle damages in biportal discectomy. Consistency across pathologies, multiplied by coverage of the 2 most common lumbar operations. This is, to our knowledge, the strongest evidence base on biportal endoscopic spine surgery to date. First, equivalent ODI. Biportal matches the microscope in functional outcomes at 1 year. Second, 0 wound dehiscence. In both RCTs, a reproducible safety signal. Third, no added cost, equivalent cost, and equivalent qualities, with a 94.9% probability favoring biportal at the Korean threshold. The clinical advantages come at no economic penalty. 2 multi-center level I RCTs. 3 post-hoc analyses. 1 coherent message. I thank my co-investigators.